and welcome to the Jerry on Ice version of the PT on Ice Daily Show. My name is Christina Previtt, and I am going live on Instagram today to talk a little bit about bone-on-bone arthritis and what we know about radiographic changes in the knee and what that means for us as physical therapists. It's been a really crazy couple of days. This weekend, Dustin and I were in Casper, Wyoming, teaching the modern management of the older adult course. It was amazing. We had 36 clinicians who were just so eager to learn. And so we had a lot of fun. We did a whole bunch of stuff with like reactive balance, and we lifted some weights, and 14 people PR'd on their deadlift because they had never realized that they can lift so much weight. And just imagine how that transfers over. And when I got home, we got dumped with snow. I'm in Kingston, Ontario in Canada. And so we live in a country house, and our propane stopped working today. And so it's been a really crazy couple of days. But I'm glad that our internet is still working and that I'm able to get onto the podcast. Okay, so today I thought I would talk about an article that's been making its circulation on social media over the last couple of days. And so the article is called Modeling and Predicting Osteoarthritis Progression, Data from the Osteoarthritis Initiative. And Halilaj is the primary author. I hope I didn't butcher his or her last name. And it's a study that's out of Stanford. And so the conclusion that some people were making was that it was another study that was showing that structure doesn't predict pain. And the idea that what we see on an x-ray may not be indicative of pain and function from arthritis in the knee. And that has been a really common theme that's gone around the internet. And I think it really does stem from the idea that we don't want our clients to be afraid of their images. You know, one of the terms that I hate more than anything else is degenerative disc disease, because it sounds so bad, and it's arthritis in the spine. And so it's one of those things that often scares my clients when really it can be something that a lot of people have. Okay, so let's talk about this study first, and then I want to kind of extrapolate. So just like any person, like I want a study that is going to confirm my biases, and I am definitely a person that doesn't want to just be dictated by what the radiographic pictures say about people's pain and function with arthritis. And so if you read through the abstract, you would think that you're right. There is no connection between radiographic progression of osteoarthritis and knee pain and function. However, as you start to read the article, that's not exactly what the article is saying, and let me explain. So what this study tried to do was a secondary analysis of a longitudinal study that was completed in the US. So it was called the Osteoarthritis Initiative, OAI, and this was a multi-million-dollar longitudinal study that took in over 1,000 people who were at high risk for the development and progression of osteoarthritis. And they followed them forward for 8 years, doing sequential. Every year they would do a radiograph of their knees to see, one, if there was any structural changes to the knee, and two, was there any increase in pain, and 3, was there any change in function using the WOMAC, which is actually an outcome measure out of McMaster University, which is where I'm doing my PhD, that looks at pain and function related to arthritis and has been very well validated. And so what this study tried to do was fit individuals with an algorithm like an equation that we could use, and we could plug in their radiographic evidence, plug in their pain, and say, what percentage can we predict that this person will have either a decline in function or require surgery or one of those deteriorating outcomes. What they found was that there wasn't a one-to-one correlation between joint space narrowing and pain. But what they said was that there is a connection for some people. There is just a lot of variability. And that's what we know. So what they said was for radiographic changes, it required 2 sequential x-rays for us to have a high predictive power of worsening of arthritis over time. So you had to show between a baseline and 1 year difference, some radiographic change, and that would predict if an individual was down a progressing or a worsening arthritis pathway and it was going to continue to decline, or in a non-progressing arthritis. And those were the 2 clusters that they identified. So they identified that there was 2 groups, one that was having a pretty steady progression of osteoarthritis changes in the knee, and another group that didn't. For the pain group, they had 3 clusters. They had a stable group, a worsening group, and an increasing or a decreasing in pain group, or an improving group. And so because you couldn't necessarily 100% blend the arthritis progressing group and the steady pain or worsening pain group, they weren't able to, without a doubt, create a perfect equation that identified that an individual was going to have worse pain based on just pain and just the radiograph. Now, why am I talking about this article? Because one of the things that we have to be careful about in physiotherapy and physical therapy is that we don't just read the abstract and make a conclusion that isn't necessarily true. What it was saying is that for some people, a worsening on a radiograph is going to increase pain, is going to decrease function, and is going to potentially lead to the need for a joint replacement. So that is exactly what that clinical care pathway would look like. What it's saying is there are other factors that are involved, not just radiographic changes and pain, that are going to predict for some people that they are going to stay relatively stable over a period of time, or they are going to improve. And we know that. As a physical therapist, I don't think we ever believe that it is a one-to-one connection, that if you show this picture or you come in with pain on the interior or the medial side of your knee, you automatically have a meniscus injury. That is just not the case, and it is never the case. And we know that there are so many factors into our experience of pain, our experience of function. And as they continue to look at different confounding variables in this modeling, so they were trying to fit those 2 variables into a mixed effect model. And their conclusion was it's more complicated than that. And we have to cluster this in a particular way that includes other variables. And that's exactly what we know. And so they were saying that some things like our strength, some aspects of our diet, if we were sleeping, if there was aspects of depression involved in an individual, that those were significantly confounding variables to making a connection that purely linked osteoarthritic changes or progression on radiograph and pain and function. So where did the bone-on-bone arthritis not leading to pain come from? So there are 2 ways that we can look from a cross-sectional perspective or a longitudinal perspective on the progression or natural history of any sort of chronic condition. And arthritis is a chronic condition. So they took individuals, and those with knee pain and without knee pain, and gave them an x-ray. And they said, they blinded radiologists and said, can you read this report and give us your results? And then we are going to compare the radiographic results of individuals who are asymptomatic, have no pain, and those that are symptomatic. And what this population study showed was that there are individuals who have signs of radiographic changes on their x-ray who do not have pain. Just like there are signs for people who do have radiographic changes and do have pain. So as a physical therapy community, myself included, we were saying that we are not our image. And I have said that to my clients over and over again, that just because you're showing signs of arthritis, arthritis can be like gray hair. It can be like wrinkles on the inside, and we don't necessarily have to have pain and decrements in function. However, when we are looking at people over time who do have pain from arthritis and we follow them over time, we see that when we have a continual progression of radiographic changes, it is associated with increased pain and decreased function. And so let me explain. So the Osteoarthritis Initiative, this longitudinal study, took people and followed them sequentially over time. When we are looking at the radiographs, so all of these people had symptomatic arthritis coming into the study. What they showed was a progression. For some individuals, they had a steadying and they didn't have a ton of change in radiographic evidence on X-ray over time. But for some, we saw a decline in function and a decline in joint space. The way that we conceptualize this is using the Kellgren and Lawrence scale. It's a scoring system that goes from 0, which shows no osteoarthritic changes, down to 4, which is showing significant joint space narrowing and multiple osteophyte formation. What these studies have showed, what this longitudinal data has shown, is that individuals who move especially more than 1 grade across this scoring system are 2.5 times more likely to have an increase in pain and a decrease in functional performance. So that is showing that if we are seeing declines in joint space, that we are also seeing a decline in function and an increase in pain. It also shows that people who are progressing through these stages or this scoring system and it is becoming more severe are also more likely to have a joint replacement, which makes sense because that's one of the criteria for going on the wait list in Canada or having a joint replacement in the US. So what's the end goal with this? So one of the things that I want to come out of this is that we cannot just pick one study and say, yep, now it means that you can have bone-on-bone arthritis and no pain, and that's the end of the story, because that's not true. If that was true, we would have the same type of change in clinical care that we are having with back pain. And so in Canada, when we've been showing with some of the imaging data that unless you have an acute neurological injury that is going to require emergency neurosurge, the use of MRIs to diagnose if you have stenosis versus arthritis versus a disc bulge really doesn't affect our clinical care pathway. And we know that as physical therapists. If someone has a disc bulge, we're going to treat the symptoms that we see in front of us anyway. The MRI isn't necessarily going to change our course of care. So what did that mean for the healthcare system? That research was so strong that in Canada, now if a primary care physician is looking to order an MRI because of symptomatic low back pain, they have to give a justification as to why this could potentially go to neurosurge or a neuro consult. And if it does not, then or if it is not deemed severe enough for that to happen, the primary care physician will not be reimbursed for the MRI, and they are actually expected to pay for that imaging. That is because what we've seen in the research has been so strong that we, without a doubt, now know that unless there's some sort of, but we were wasting so many healthcare dollars trying to do these MRIs, and then it wasn't really changing what we were doing in terms of our course of care. In arthritis, that is not the case. We are seeing pretty solid evidence that individuals with symptomatic knee pain and decrease in function relating to arthritis of the knee, if they are having progression over time of the amount of joint space narrowing, osteophyte formation, or ossification at the end plates of the joint, that they are more likely to have an increase in pain and a decrease in function. This isn't for everybody, but because that evidence is still there, it is one of the criteria for eligibility for a joint replacement. That being said, it is one of the criteria. When you go in, and I'm speaking obviously in the Canadian context, and you speak with an orthopedic surgeon, they look at not only your x-rays, but they ask you, how are you doing from a mental health perspective? How are you doing from a quality of life perspective? How are you doing from a functional perspective? And those four things, the radiographic changes as well as the subjective and objective measures of your pain and function, are going to decide if you are eligible for joint replacement. And so I think that's a really important differentiating criteria. We can still use the fact that individuals with changes on x-ray don't necessarily have pain as a way to educate our clients to not be fearful around arthritis, because I think that's an important concept, that we know that we have changes in joint space and we have joint space narrowing that happens as we get older. It's a necessary and normal part of the aging process. That doesn't mean that we're going to have pain, but if we do have pain, I feel like sometimes if we are saying that bone-on-bone arthritis means nothing, we might also be not necessarily helping our clients because we are almost dismissing their complaints, and we are going against what their physician may have said is one of the reasons why they are experiencing this discomfort and why they're experiencing this loss of function and decrease in quality of life. So when it comes down to it, I think our communication style and what we are doing with the research is really, really important. And we need to be careful not to data pick and use one study that is a population-wide study, not a clinical population, but an overall population level study, to dictate what happens and dictate our conversations exclusively. And so just something for everybody to think about and kind of some food for thought. This was one of those things that for me was something that I truly believed into, and so I can understand where some of that confirmation bias comes from. Now, at the other side of this, does that mean that just because there's all these radiographic changes that a joint replacement is inevitable? The answer is no. And so there are systematic reviews that were published in 2015 and 2017 that looked at knee extensor strength and pain and function related to arthritis. And what the 2017 systematic review said was that individuals with low knee extensor strength were more likely to have pain related to arthritis and were more likely to see a decline in function. But that didn't mean necessarily if you had weak knee extensors or quads, it did not mean that you were going to have an increased risk for progression of arthritis. So I think that was another important finding, that we can improve function without changing joint space by doing strengthening. And that is something that I think PTs know a lot about, and where we can get kind of confused and sometimes make bigger claims than the research actually supports us making with some of our strengthening and some of our conservative management. And the times are also changing. So just because there's radiographic changes, a lot of primary care physicians now in Canada are still saying try conservative management first. Just because knee arthroplasties are more common doesn't mean that it's no big deal and that there isn't complications and risks. And so just some food for thought. So you can have changes and you can have joint space narrowing without pain, but if you are having progression of joint space narrowing over time, you are more likely to have increase in pain and increase in function. And individuals who elect for total knee arthroplasty do tend to have progression and worsening of joint space over time. They are at increased risk for needing surgery if we are seeing progression in joint space narrowing over time, as done by the Kalgren-Lawrence criteria. That being said, conservative management like knee extensor strengthening and some of those more conservative measurements for managing arthritis can definitely improve pain, can definitely improve function, and it's something that we as PTs see a lot of in our clinical practice. All right, I rambled on for almost 20 minutes, but I hope that that was a good PT on Ice for you guys. It was something that was really interesting for me. When I read that study, I kind of recognized my own confirmation bias, that I was looking for a study that was going to say what I wanted it to say, and then it didn't. And it made me also be very aware that sometimes, that abstract reading doesn't necessarily translate into what the study says. And we need to be careful about the information that we're trying to glean out of a study based on just reading the abstract, because it can give us information without context, and the context can change how we interpret that data. So it's really, really important. And I know that I'm kind of going on my PhD research rant, but something that we need to be really careful about. And we want to make sure that we are giving the right information, especially in the world of social media, where those things get shared hundreds of times and the information isn't exactly correct. All right. I hope you guys have a wonderful Wednesday. If you are stuck in the snowstorm like I am, I hope you guys get yourselves out safe and you get your workout in because you're shoveling yourselves out of the snow. Otherwise, I will see you guys in a couple of weeks. Dustin is taking on the Jerry on Ice section for the next couple of weeks. So I will see you all in almost March. All right, guys, if you have any questions, comments, let me know. I can put some of the citations below if you like, if you want to geek out the way that I did. Otherwise, talk soon. Bye.